אני חושבת שמי שיושנה כאן בחדר זה אנשים שמודעים שצריכים פארמקוביג'ילנס, לא דווקא בגלל החוקים החדשים, ושואלים איך עושים את זה, כי כולנו יודעים, ונצפה לכם רק בהמשך, כשבאים למנהלים שלנו, אז מי צריך פארמקוביג'ילנס? כי זה סתם הוצאות, ואז לא מרוויחים יותר כסף, ואף פעם אין מספיק כוח אדם, אף פעם אין מספיק תקציבים, אף פעם אין מספיק תמיכת IT, אבל בסוף כשיש ברוך ויש בעיה, אז מפילים את האשמה עלינו. והדבר השני שתמיד אני אומרת לצוות שלי, אנשי הפארמקוביג'ילנס, וכשתראו את אנשים בטבע, מרביתם זה אנשים שמגיעים ומתחתנים לכל חייהם, פארמקוביג'ילנס זה בטח עם טבע, יש כאן כמה נציגות שלי, שאתה מנהל אותם, כבר נמאס להם בטח לראות אותנו בוקר, אבל ברוך, זה מחויבות מסוימת. מחויבות מסוימת לפארמקוביג'ילנס, זה מחויבות, בוא נגיד, למחויבות לחולה. למטופל, ולכן כולנו עושים את המקצוע הזה למרות שהוא מתסכל. עכשיו, היו לנו כמה דיונים שהאמת שהאירין היא זאת שדחפה ועשתה, שנעשה את הישיבות הללו, ונתחיל לחשוב איך עושים, באיזה מסגרת עושים את זה, וניסינו יותר משרד הבריאות ופחות משרד הבריאות וכו'. והרעיון שלה בוא נהיה חלק מהאיזופ, היא תדבר על האיזופ ועל הצ'פטר הישראלי, ואז אמרנו, רגע, בגלל שזה לוקח לאנשים להירשם, וזה עולה כסף וכו', בואו ננסה לעשות משהו אפילו בהתנדבות, ונקח את האנשים. אבל התנדבות, זאת אומרת שאנחנו מובילות עכשיו, אבל אנחנו מקווים שעוד אנשים יצטרפו להוביל ולעשות את הדברים. ולכן התנדבנו טבע לארח פעם הראשונה את המפגש הזה. אני מוכרחה להגיד שהייתה הענות יותר משציפינו ושמחים אנחנו, אבל באיזשהו שלב אמרנו עוצרים, כי עוד רגע אי אפשר להכניס לחדר הזה. ונצטרך לחשוב איך עושים הלאה, והסיבה שגם שהתנדבנו, גם שטבע חשבה שבגלל שלנו עזרו, אנחנו צריכים לעזור, וגם בגלל שרצינו בסופו של דבר שכל מי שרוצה יכול לבוא ויוכל ללמוד ויוכל לראות את הדברים כאן. והמטרה שלנו יהיו כאן, וזה בערך הפורום שאנחנו רוצים למצוא בהמשך, שיחה של 2 עד 2.5, שיהיו כאן הרצאה 2 על נושא מסוים, שאחרי זה לא רק הרצאה, זה יותר שיחה, לשמוע איך עושים, לשמוע פתרונות, להידיין ביחד על בעיות שיש לנו משותפות ולחשוב ביחד איך יוצרים, אולי ליצור מזה גופים הלאה. הרעיון הוא גם לא משהו אקדמי, אני יכולה להגיד לכם שבמקביל יש היום התארגנות באוניברסיטת תל אביב, שגם אירין מעורבת פה להקים משהו, הוא באמת אולי קיץ בנושא פארמקוביג'ילנס, שיהיה משהו אקדמי, אבל זה לא. כאן אנחנו מדברים על צדדים שהם פרקטיים, מתוך מטרה להקים באמת ולחשוב ביחד איך פותרים את הבעיות. אז מעבר לעניין שאנחנו כן מצפים להשתתפות כאן של האנשים והערות, אנחנו נורא נרצה לשמוע תחפיד איך היה, כי זה מסוג הדברים של ללמוד ולשפר ולנסות לעשות את הדברים קצת אחרת, ולשמוע תגובות והתנדבויות שלכם, וגם לשמוע נושאים שאתם הייתם רוצים לשמוע שנדבר עליהם יותר. אז לפני שמעבירה לאירין, אז תודה רבה לשפרה של כנסת אלה, שארגנה ועשתה את הדברים. תודה רבה לתמר, שאולי תשמע אותי מעבר לדלת, שהתארגנה גם כן בזמנה חופשי לארגן את הדברים הללו. וזהו, אני חושבת, אירין, פליז.
תודה רבה. אני שמחה מאוד לראות כמה אנשים שבאים, ולראות איך אנחנו מתקדמים. וזהו בעברית, אחר כך בדרום בעברית. Today, you know, the idea, I'm sorry because I think that I will be the only one to want to speak English, so I can understand, but I'm not sure that I will be to say everything as I want to say and understand what you say, so I will do it in English, but I will understand when you're speaking, everybody speaking in Hebrew. So, the idea of the hot topics of pharmacovigilance is to build a really good cycle of meetings where we will together have a cookbook. We will first speak about one subject and then we will exchange our tips and how par place we are doing things. And this is the idea of this cycle. So, why are we here? Because adverse reaction is the fourth or the fifth, according to the sources, or a cause of death in Europe and in US. I don't know in Israel, but this is why we have to do pharmacovigilance, because we are not only saving one life, but we will save many lives in doing pharmacovigilance. So. A very brief presentation, because Khedva has already spoken about that, about the program in hot topics that you have certainly all of you received, and then we will try. What the idea was before to start the cycle of hot topics was to give you a very holistic approach of what is pharmacovigilance and what are the pieces that you have to build for your pharmacovigilance system, and then Khedva will present you where we are coming from and where we are going, and then you will be the one speaking. I have found out this slide, which was exactly 1 year ago, which was our first meeting in Rehovot in Bioforum premises, and so I'm very glad to see that after 1 year we are succeeded to be together. So what is our goal? It's to improve and harmonize pharmacovigilance system, to have a better awareness of patient safety, to be all together. Pharmacovigilance, it's a system. We need to have the regulatory people, we need to have the people from the MOH, from the Kupot Cholim, from the hospital, from the patient, from the industry, and together we will build the pharmacovigilance in Israel. And we are here to be a think tank to help the Ministry of Health to implement its new regulation, to make some input, and to help also for the compliance. So what did we do during this year? First of all, we have been endorsed by the president of ISOP International, who was very enthusiastic about our project, and then the Tel Aviv University Public Health School also has decided to do something in the field of pharmacovigilance, and we are building this educational program. We have made a lot of communication about the conference that we wanted to organize in December, but then we had the MOH conference, so it was their kavod to do this. And in the ISOP annual meeting in Pisa, we have presented a poster about what is the ISOP Israel chapter. We have presented our program to the executive committee, and it was announced, and we were 3 Israeli with Luis and Ophir. So that it was the first time I think that some Israeli were in the ISOP. So and then we are starting to have a joint collaboration with some other universities, and we have got the support of Dorit has sent me a very nice mail saying that it was a very good idea to have this hot topics, and that she will do her best to be there for all the meetings, even if she was not able to attend this one. So the program, we will have the next one in with the Pharmacist Association on the PSUR and PBR new format. And after that, SDA, Safety Data Exchange Agreement. How do you organize your data with your different partners? Safety database and electronic transmission to Vigilance, to MOH, to FDA, literature survey, quality in pharmacovigilance, and risk management plan. And of course, it's open because it's for all of us. So if you have any need, if you want to have a new subject, it's just up to you. So the advisory board, Khedva is the secretary, Yehudit is the advisor for educational program, Mira for the academy, and as well as the Professor Daniel Cohen, and Luis for the industry. Special thanks for Khedva for hosting us for the first Hot Topics meeting, and for launching this cycle, and for being supportive at the very beginning of this idea. Yehudit, thank you very much, because Yehudit has been the first one in Israel to believe in pharmacovigilance 5 years ago. She has opened the door of Bioforum, and we have made the first courses on pharmacovigilance, where I've met many of you. And Shifra, thank you, and Tara, thank you for all the organization of this meeting. So next step, please register to ISOP International, because for the time being, I don't know for how long, it's free to be part of ISOP Israel, but we need to be at least 10 people registered in ISOP International just to see that we are doing something. So the official creation will be in the annual meeting of ISOP 2014. We are planning an intensive summer course in Tel Aviv University. We have the Bioforum seminars that are already planned, and we hope very much to involve Bot-Cholim and clinical pharmacovigilance to have all these stakeholders. So someone told me, you have to make people dream, and I said, this is the very place where dream is becoming reality, and now it's in our hands. So now, going to what is a good pharmacovigilance system. Where to start? This is a difficulty. So I like very much this implementation plan from the European agency, because they are saying we have a new regulation and these are the way we want to implement things. We have 3 priorities. First priority, any process, we will always follow these 3 priorities. First one, we have to contribute to public health. Second, we have to improve the transparency and the communication. And second and third, simplify the process. All topics will be according to this priority. So I think that it's a very good idea for any of us creating a new pharmacovigilance system to think exactly to where do I start? I start for what is contributing to public health. And then we have 4 domains of activity, and in each one we have the three level of priority. First of all, to collect the information, the data, safety data on our product. Then to analyze the data and to understand what is the safety profile of our product. Then to do all the regulatory action to safeguard public health. And last, to do the communication between all stakeholders. So I think that it's a very good example to follow what EMEA has set up as its own domain of activities. So if we are going to the good pharmacovigilance practices, they are listing all the clinical pharmacovigilance, the critical pharmacovigilance processes. In fact, I think that they have listed everything. From business continuity to the case handling, to the PSUR, the signal management. I don't know what we can add on that. So we have everything. So okay, so this is something that we have to do, shall do. And then when we have to implement a pharmacovigilance system, the first step is to establish a work plan. Because if we are inspected, they will they know that we are starting from something little or from scratch, whatever is our level. But what is very important for the inspector, and I'm saying that in Europe, but I'm sure that it will be the same for the MOH in Israel, that when they see that you have a work plan, you know exactly how you will do things, they can understand that not everything could be built in one month. So this is, for example, just an example that this is what I will do, the training for our PV staff on the regulation, on the GVP module. GVP is for good pharmacovigilance practices. Then I will implement the PV system master file. Then I will update my SOP, etc., etc., so that you have something with some deadline, and that you will do it according to your work plan and to your resources. So what I will try to give you is to give you all the pieces that could be, for instance, the SOP, the name of your SOPs, and what you have, all the key points that you have to look at each kind of process, and could be also the role of the EU QPPV, what he has to supervise, and also what do you have to look at if you have an inspection or if you have an audit. So this tool is like you can take it at the level that you want to take it. This is my way of organizing things. Of course, it's very much inspired by Brian Edwards, if somebody is knowing him, and I've a little bit changed things. But I think that in the pharmacovigilance system, we have some activities we are really dedicated to the safety profile and benefit risk assessment of our product. This activity, I have made a list of all this activity. We have all the aspect of technology, and we have more and more, so we need more and more engineers and IT. And we have all the resources and structures, the QPPV, the regulatory, the PV system master file, and then we have the risk management system. Let's see. We are now in the safety profile surveillance and the benefit risk assessment. First of all, we have the individual report. It's obvious for me, but it's always good to say it again. Pharmacovigilance is a holistic approach, meaning it has to be applied in pre-marketing, in post-marketing, same tools, same database, same processes, same thinking. So in the individual report, you have the spontaneous report, clinical trial, from the literature, and then something that you have to think about, some tips. Don't forget off-label use, misuse, medication errors. Always have a company comment at the end of your case, for each case. When you have a case, at the end of the narrative, you do your company comment, which is your medical analysis of your case. This case is serious and expected, and we think that this patient has some risk factor. Let's say that, and for instance, he has some risk factor of bleeding and receiving an anticoagulant, so he's bleeding. So these are the risk factor, and this is our assessment, etc. Flag your events of interest. It will help you for signal management. I have an anticoagulant. I know that the bleeding are my events of interest. I want to find them very quickly. In your literature search, you have to do at least 2 to 3 databases. You have to check what are the reporting criteria of your competent authority. And don't forget to do reconciliation with medical information, technical complaints, and it's very important to do the reconciliation to be sure that something in the complaint was not something which could be a potential case and which was so you have to do a process to make the reconciliation. One system, one database, pre and post marketing. This is the whole message. You have all your case by case. First case, you see your patient is falling. There is nothing in the clinical trials. I've never heard about something. You think that it's very unlikely related, and then so you do your assessment. You report a case, and then when you put together your periodic reports, you see that. In fact, you have several patients who had fallen. One has fallen in the escalator, the other one has fallen in his kitchen, and eventually you understand that there is something. Perhaps there is an hypotension, perhaps that you have not understood at the beginning. So periodic reports will help you to do the analysis of your aggregate data. So again, and this is a new PSUR, PBRER in the ICH, we will speak next time, strengthen medical analysis. And the same approach for your DSUR, which is in pre-marketing, for your PSUR, which is post-marketing, for risk management plan, which is when you are asking for a new authorization. Then, again, we have individual report, periodic reports, and we have all the very hot topics, we could say, in pharmacovigilance, answers to urgent queries from the authority. How do you access your database? How do you access your data? Handling urgent matters. How do you do the withdrawal? Not only for technical for batch recall, but something because you have a problem of safety. And how do you do your signal detection and signal management? So you have to do that. For each product, you have a different strategy. So you have to think about what source I will use, what periodicity, how do I do my data mining, and you have to set up your keywords and your events of interest. And of course, DSMB safety committee when you're on post-marketing, very, very good tip, very tactless. You want your top management to give you resources. You want them to understand that you have a problem. Just set up a safety committee with people from marketing, with people from regulatory, from the manufacturing, people who that every quarter you will meet them and you will tell them what you are doing and how it's interesting pharmacovigilance. And then when you have a problem and you have a crisis, your safety committee is already here. Technology, safety database, and of course electronic reporting. I've met people from Pharma Israel just a few minutes ago, and they were very, now that there is the electronic transmission also in Israel, you have to think about how you are organizing your pharmacovigilance database. They have to be E2B compliant with XML format. There is one international format, and you have to stick to that. You have to be able to edit FAMS or to edit MedWatch, to do all the queries and all the data migration, sending, importing, exporting XML. And then for the electronic reporting, in Europe, we have the hydrovigilance certification, meaning that you can handle this only if you have been through the course in hydrovigilance, and it's one of the most awful exams that I have had. 5 days, completely crazy, with ICH by heart, E2B, and also IT, convention coding and convention. It was absolutely awful. And in Dublin, and it was raining. It was awful. So, and then you have also to think about your culture. First time that I have to think about what is the culture, why I'm a pharmacovigilance, I'm a physician, why I'm to do something with the culture. Yes, you have to be sure that somebody will answer night and day, and who will answer in Polish, and who will answer in Hebrew, and who will answer in Arabic, and who will answer in Russian, and somebody like me who doesn't understand very well Hebrew, can I speak in English? So we have a lot of things like that to think about. And how do you organize yourself with all your affiliate or your headquarter? And then the resources. The role of the QPPV, here it's the UQPPV, but it's the same for the QPPV in Israel, and the national QPs. So you have to think about the job description, the liability, the registration to the MOH or to the email. You have to think about the backup. And to test, don't forget to test that at B'Yom Shishi, Charei Shabbat Nichnas, you're sure that somebody will answer, even if it's religious, even if it's Shomer Shabbat. And so then you have to think about your pharmacovigilance training. This is something that it's something amazing, and it's wonderful because we have something, every time we have something new. Every time that I'm doing the new regulation with all the GVP, I think, okay, I have 500 slides for 2 days, which is big enough, and then I will look again in the new in the website, and again I have 100 more slides, which becoming a little bit crazy. So you have to train all the time. Don't forget training records. And quality assurance and quality control, PV system master file. Everybody was completely afraid of what is a pharmacovigilance system master file. It's awful to organize. I can tell you because I have organized it 5 years because before it was mandatory, and it's a wonderful tool. It's a little bit difficult to organize at the beginning, but when you have done it and you are used to it, it's a very friendly way to follow your quality and to do it in a very systematic way. Filing, archiving, data protection. We are in Israel, so that if you're receiving some data from Europe, you have to think about the data protection and data privacy. When you are in Europe, you have signed the European Union data privacy policy, but when you are outside of Europe, even if you are the headquarters in Israel, you have to organize and to prove that the safety will be safe. The data will be safe according to the data privacy, so that either you are in the safer harbor or you are organizing how many logs do you have, how many passwords and things like that. Safety data exchange agreement, very, very important. Who is responsible for what and when? And this is, I have known company who has been closed, suspended. They have a suspension of the whole company because the safety data exchange agreement was so bad, and they have no QPPV also, and they have cases in all the cupboards and everywhere, and it's true, and it was in France, and one of the critical findings was that the safety data exchange agreement was so bad that nobody knows what he has to do. Risk management. What is it? It's really to act and to be proactive and to find solution and to prevent the risk, the adverse reaction. So in Europe, you cannot put a new product on the market, even a generic, without a risk management plan. And now they have linked the PSUR, the DSUR, the RMP. Risk, also, you can implement your risk management plan and your development risk management plan during the clinical trial, and it will help you. I can tell you. I don't want to be more take more time, but if you want, we could speak about that afterward. Post-authorization safety and efficacy studies. Now in Europe, you cannot have any new product without post-authorization studies. So you have to organize how do you collect and handle your cases which are solicited or not solicited. Risk minimization actions. This is something which is not only in the risk management plan, but it's always that you have to think action. You have one case which is like hepatitis and the patient died. You have immediately, this is like a big signal. What can I do to avoid this? We have like the Vioxx story, we have the Cerevastatin, we have many stories to understand. Educational material, and you have also to measure that what you are doing is really efficient. And then you have to be prepared for any safety crisis. And so you have to have an SOP on the crisis. You have to do simulation, and it's very, it's very nice. And when you do it, when you're very quiet, it's wonderful. And afterward, if you have any problem, you are very happy to have a safety committee and to have a safety crisis management SOP. This is pharmacovigilance. The safety profile, individual reports, periodic reports, technology aspect, the database organization, communication, electronic reporting, resources with the QPPV role, the backup, the pharmacovigilance training plan, quality plan, PV system master file, data protection, safety agreements, and the risk management, safety that you have to write this risk management plan, and you can start in your clinical trials. Action, action, action. And this is my last slide. I was in a restaurant in Paris, and suddenly I saw this very beautiful. I took a picture and I went to internet, and it's saying strength and energy with product Lavoca, irradiated food. When Marie Curie had discovered the radiation, they saw that it was wonderful. It will give us a lot of strength. I think that all pharmacovigilance patents must have this picture, just to say we never know what could happen with our product. Thank you very much.
Thank you, Irene. Will you share the slides with the team here?
Yes.
Okay, because I think that what you got here is huge information.
Yes.
And that's the reason we are going to the second part of discussion, because I think if you look at all of that, it's frightening. It's like, wow, how can you do it? And that's the reason to go to the next presentation, which is not presentation, it's more discussion. Now,